Hi friends, once again welcome back to the Nurse channel. So you are watching the ESIC AIIMS Norcet series which I have already started, and several videos already we have uploaded, and whoever didn't watch those videos, kindly watch those videos because all videos and its explanations will definitely help you to prepare well for the upcoming AIIMS Norcet and the ESIC examinations. I know previous videos, one of our subscribers have asked about the syllabus for the ESIC examination. So the detailed syllabus and the other informations definitely you will get from our website. We can go through our website, and in short I can explain like the questions can be asked from all aspects of nursing subjects including anatomy and physiology. And one peculiarity of this time exam is that the GK, general knowledge, for as like the previous years, general knowledge questions will not be available as per the information of the syllabus from the UPSC website. So in the UPSC website they didn't mention anything about the GK questions, but in the previous ESIC examinations there are some amount of questions will be there from the GK and aptitude. So that questions will not be there in this examination as per the UPSC website. Okay, so the other details and all already we have uploaded a video, and the details are there in our website also. We kindly go through that. Okay, so without losing time, we will start our session, today's session. And before that, whoever not yet subscribed our channel, kindly subscribe and support us. And I request everyone to watch the video till the end without skipping, because the explanatory sessions in each questions are very important. So you will get a bunch of information from this video. So inviting you all once again to our ESIC Norcet series, and here comes your questions. So let us start with the first question in this series. So the first question from the renal system. So the question is in the screen right now. So the question is, what is the leading cause of CKD in India? So leading cause of CKD. CKD means the chronic kidney disease. Chronic kidney disease in India. So the options are option number A, hypertension. Option number B, diabetic nephropathy. Option number C, renal infections. And option number D, polycystic kidney. So which is the leading cause of CKD in India? So what is the answer? So the answer is option number B, obviously diabetic nephropathy, not hypertension. Okay, you may be confused with these two options. So diabetic nephropathy is the leading cause of CKD in India. So the diabetic nephropathy, which is also known as the diabetic kidney disease, is the chronic loss of kidney function occurring in those with diabetes mellitus. So diabetic nephropathy is the leading cause of chronic kidney disease and the end-stage renal disease, that is ESRD, globally. The triad of protein leaking into the urine, that means proteinuria or albuminuria, then rising blood pressure with hypertension, and then falling renal function is common to many forms of CKD. So that is a diabetic diabetic nephropathy. Then management of this diabetic nephropathy currently centers over four main areas, that is the cardiovascular risk reduction, glycemic control, blood pressure control, as well as the inhibition of the RAS system. So RAS system and all I am not explaining in much detail, so you can refer to these things later. Okay, so moving on to the second question in our series. So gastric ulcers are commonly located on which part of GIT? So you know that gastric ulcers, duodenal ulcers. So here the question is, gastric ulcers are commonly located on which part of GIT? So the options are option number A, greater curvature, option number B, lesser curvature, option number C, antrum, and option number D, fundus. So where gastric ulcers are commonly located? So what is the answer? So the answer is option number B, that is a lesser curvature. So this we can explain with the help of this picture. So you can see the picture of the stomach here, and we have the lesser curvature area here, and this is a common point for the gastric ulcers. Okay, so gastric ulcers are commonly located on the lesser curvature between the antrum and the fundus. Okay, between the antrum and the fundus. So the majority of the duodenal ulcers, that is additional point. So here we can see the duodenal ulcer. These are located in the first part of the duodenum. Okay, so these are located on the first part of the duodenum, and this gastric ulcers are commonly located on the lesser curvature. Okay, so two very important points you are getting out of this question. Now we can see the third question in our series. The question is, which among the following holds a predominant role in the regulation of prolactin secretion? So this is an important question from the endocrinology. So you can see that the question is regarding the prolactin secretion regulation. Okay, so this is very, very important. So prolactin secretion regulation is by which among the following? So options are option number A, GABA, option number B, FSH, option number C, dopamine, and option number D, bromocriptine. So among this, which is the which one regulates the prolactin secretion? Okay, so what is the answer? So you need to think a little bit regarding this thing, otherwise you can't answer this question. So we will be explaining regarding this regulation very shortly. So before that, we will see the answer for this question. So the answer is option number C, that is a dopamine. Okay, so how dopamine is related to prolactin secretion, that I will be explaining now. So prolactin, you know that it is secreted from the pituitary gland in response to eating, mating, estrogen treatment, ovulation, and nursing. Okay, so you know that what is a prolactin. So it is secreted heavily in pulses in between these events like eating, mating, estrogen treatment, ovulation, and nursing. So prolactin plays an essential role in the metabolism, regulation of the immune system, and pancreatic development. So not only that milk ejection and all, but there are other functions of the prolactin that is a essential role in the metabolism, regulation of the immune system, and pancreatic development. So what is the role of dopamine? So you know that dopamine, it restrains the prolactin production. So the more dopamine there is, the less prolactin is released. That means prolactin itself enhances the secretion of dopamine. So this creates a negative feedback loop. Okay, so whenever there is an increase in the prolactin level itself will release the dopamine, and this dopamine in turn reduces the production of prolactin. So this is a negative feedback loop. So little more clear. So the dopamine inhibits the release of prolactin directly from the pituitary gland only when prolactin secretion is high. Okay, so the hypothalamus secretes at least two factors that regulating the prolactin secretion. So that is a prolactin releasing factor and a dopaminergic prolactin inhibiting factor. So there is a prolactin releasing factor and a dopaminergic prolactin inhibiting factor. And one more option was there, that is regarding the bromocriptine. So you know that bromocriptine, it blocks the release of prolactin from the pituitary gland. So this is the drug that can be given to suppress the lactation and all. Okay, so bromocriptine, it blocks the release of the prolactin from the pituitary gland, and prolactin affects the menstrual cycle and milk production. Bromocriptine is used to treat certain menstrual problems like amenorrhea in women, and it stops the milk production in some men and women who have abnormal milk leakage. Okay, so this is bromocriptine. So that the other things were the neurotransmitters like GABA and all. So this is bromocriptine, and it is a medicine that can be used to treat the excess milk production or to stop the milk production in certain cases. Okay, so that's all regarding that question. So moving on to the next question in our series. So the drug of choice for trigeminal neuralgia. So this is a very frequently asked question in competitive examinations. Drug of choice for trigeminal neuralgia. So the first option is sodium valproate. The second option is carbamazepine. The third option is tramadol, and the final option is levetiracetam. So which among the following is the drug of choice for trigeminal neuralgia? It's an easy question. Answer is option number B, that is carbamazepine. So carbamazepine and oxcarbazepine, okay, these are the first line treatment options for trigeminal neuralgia and offer meaningful initial pain control in almost 90% of the patients and 19, although this may not be sustained in long term. Okay, their mechanism of action is the modulation of voltage gated sodium channels, leading to a decrease in the neuronal activity. So this is the mechanism. It is acting on the voltage gated sodium channels and thus reducing the neural activity and the pain. So it is an anticonvulsant medication which is used in the treatment of epilepsy and neuropathic pain, and it is used as an adjunctive treatment in schizophrenia along with other medications and as a second line agent in the bipolar disorder. So these are the indications for the carbamazepine therapy. So the question what we have asked was regarding the trigeminal neuralgia, and the mechanism of action we have explained, and the other uses are it is an anti-epileptic agent, and it is a drug which is used for the neuropathic pain and adjunctive treatment in schizophrenia and a second line treatment in the bipolar disorder, that is a carbamazepine and oxcarbazepine. Okay, moving on to the fifth question in our series. Which virus causes increased mortality due to acute liver failure in pregnancy? So the question is regarding a virus which can cause increased mortality in pregnancy due to acute liver failure. So that is a question, and the options are option number A, hepatitis A, option number B, hepatitis B, option number C, hepatitis C, and option number D, hepatitis E. So among this, which hepatitis can cause increased mortality during pregnancy? So answer is option number D, that is a hepatitis E. Okay, this is also very important question. So we know that pregnant women with hepatitis E, that is particularly those in the second or the third trimester, are at increased risk for acute liver failure, fetal loss and mortality. Okay, liver failure, then abortion and mortality. So around up to 20 to 25% of the pregnant women can die if they get hepatitis E in the third trimester. Okay, so this point is very important. Okay, pregnant women with hepatitis E. Okay, now the hepatitis E, little more information regarding this question. So the hepatitis E virus is mainly transmitted through drinking water that is contaminated with fecal matter, and the symptoms include jaundice, lack of appetite and nausea. Then immunological changes, why this hepatitis E can affect that much, can increase that much mortality in pregnant women. So you know that immunological changes during the pregnancy promote the maintenance of the fetus in the maternal environment by suppression of the T cell mediated immunity. Okay, so already the T cell mediated immunity is suppressed to take care of the growing fetus in the maternal environment, so rendering pregnant women more susceptible to viral infections like hepatitis E virus infections. Okay, so already the T cell mediated immunity is down in the pregnant women, and because of that, this is a chances for the infections like viral infections like hepatitis E to happen and can cause the mortality rate to increase. Okay, so that is a reason why hepatitis E in pregnancy can cause this much mortality. Okay, so that's all regarding that question. We can see the sixth question in our series. So another important question, which of the following UTIs is a common risk factor for squamous cell carcinoma of the bladder? So little important question, like, so here the question is regarding a UTI. So which organism is causing the UTI, and which organism is a common risk factor for the development of squamous cell carcinoma of the bladder? So the options are Staphylococcus aureus, option number B, schistosomiasis, option number C, Escherichia coli, and option number D, Proteus mirabilis. So the question, you should be very careful. You can expect two types of question from this. So the first question will be like which is the common organism for the development of UTIs. So the second question will be, so which among the following organisms can cause UTI associated squamous cell carcinoma? The UTI can lead to squamous cell carcinoma, that is a bladder carcinoma. So here the answer is option number B, that is a schistosomiasis. Schistosomiasis. So you know that schistosomiasis or the urogenital schistosomiasis or UGS is caused by egg-laying schistosomiasis hematobium worms dwelling within the veins draining the main pelvic organs including the bladder, uterus and the cervix. Okay, so this name please keep this in your mind, that is a urogenital schistosomiasis which is caused by schistosomiasis hematobium. Okay, so the infectious stages of the parasite larvae larvae cercariae that emerge from the freshwater snails infect the humans through the direct skin penetration. And the classical signs of schistosomiasis is hematuria, then kidney damage and fibrosis of the bladder and ureter are sometimes diagnosed in advanced cases, and the bladder carcinoma is another possible complication in the later stages. So these are the some very important points regarding the schistosomiasis, that is a urogenital schistosomiasis, and hematuria is the main classical sign of urogenital schistosomiasis, and in later stages it can cause kidney damage, bladder fibrosis, ureter and other problems, then bladder carcinoma. Okay, so another question I have, another thing what we have discussed in this question was, so the most common causative agent for both uncomplicated and complicated UTI is the uropathogenic E. coli. Okay, this is accounting for almost 75% and 65% of all UTI cases respectively. Okay, so the other question that can be asked is the most common organism for the other UTIs, normal UTIs like uncomplicated and complicated, that is E. coli. E. coli is the answer. Okay, so two important points you are getting out of this question. Now we can move on to the next question, that is the seventh question in our series. So the question is, visual hallucinations can be seen in which type of dementia? So we know that there are several types of dementia, and dementia itself is an important topic in exam point of view. So one of the questions that can be asked is the questions like this. So visual hallucination is common in which type of dementia? So the options are option number A, vascular dementia, option number D, Alzheimer's dementia, option number C, Lewy body dementia, and option number D, frontotemporal dementia. Slightly confusing, but you should mark up this question as it is, because it is very important. So the answer for this question is option number C, that is a Lewy body dementia. Okay, Lewy body dementia. So we will see what is a Lewy body dementia and why visual hallucination. Okay, so Lewy body dementia, it is a disease which is associated with abnormal deposits of a protein called alpha-synuclein in the brain. Okay, so this is another point that you have to remember. Lewy body dementia is due to the abnormal deposit of a protein, that is alpha-synuclein. Alpha-synuclein is associated with which disease condition? That is Lewy body dementia. So these deposits called the Lewy bodies, it affects the chemicals in the brain whose changes in turn can lead to problems with thinking, movement, behavior and mood. Okay, so Lewy body dementia, it is the second most common type of dementia after the Alzheimer's dementia. So the first dementia, common dementia is Alzheimer's dementia, and the second common dementia is the Lewy body dementia. And in Lewy body dementia, there will be problems with thinking, unpredictable changes in the attention and alertness, and visual hallucinations develop early in relation to movement symptoms such as slow movement, difficulty walking and muscle stiffness. Okay, so there will be movement deterioration also will be there, that physical movement deterioration along with thinking issues, then changes in the attention and alertness, then visual hallucinations, and these and movement symptoms like slow movement, difficulty walking and muscle stiffness. Okay, so these are the points that you can remember regarding the Lewy body dementia. And the answer for the question, visual hallucinations, these are more common in people with dementia with the Lewy bodies and Parkinson's disease dementia. Okay, so this is the another dementia where we can see visual hallucination, that is Parkinson's disease dementia. Okay, so that's all regarding that Lewy body dementia. Then another option what I have given was the vascular dementia. So just some important points regarding this vascular dementia. So it is a dementia which is caused by problems in the blood supply to the brain resulting from a cerebrovascular disease. So the question can be asked like, so which among the following dementia can occur as a result from a cerebrovascular disease? That is the vascular dementia. So the three types of vascular dementia are subcortical, then multi-infarct, then stroke related. Okay, subcortical vascular dementia, multi-infarct dementia and stroke related dementia. So I am not going in depth into these topics because in exam point of view this much will be enough. Then another option was that frontotemporal dementia. So this is also a common cause of dementia, and it is a group of disorders that occur when nerve cells in the frontal and temporal lobes of the brain are low. Okay, frontal and temporal lobes as the name indicates, and this causes the lobes to shrink. There will be atrophy of the lobes, frontal lobe and the temporal lobe, okay, and thus causing the symptoms. Okay, so that's all regarding the some information regarding the dementia, some types of dementias. So moving on to the 8th question from our series: which among the following pathophysiology explains GERD? So what is GERD? Gastroesophageal reflux disease. So I am giving you some options. In that options you have to find out what pathophysiology underlines the development of GERD. The first one is the PUD, that is peptic ulcer disease. Then option number B is the gastritis. Option number C is the Barrett's esophagus, and option number D is the transient decrease in the pressure in LES, that is a lower esophageal sphincter. So another easy question, but was asked very frequently in other competitive examinations. So the answer is obviously option number D. There will be transient decrease in the pressure in LES. You know how much is the pressure in the lower esophageal sphincter? So that we can see in the explanatory section. So you know that GERD, it is a chronic upper gastrointestinal disease in which the stomach content persistently and regularly flows up into the esophagus, resulting in symptoms and or the complications. Okay, so here you know that GERD, it is a stomach contents are persistently and regularly flows up into the esophagus and causing the symptoms. So the muscle contractions follow a normal pattern down the esophagus. Okay, so what is happening normally is there will be a muscle contraction that can be follow a normal pattern down the esophagus, and there is a normal pressure of the lower esophageal sphincter that is about 15 millimeter mercury, and the pressure is less than 10 millimeter mercury when the LES relaxes to let the food pass into the stomach. Okay, so it will be normal pressure, the LES will be 15 millimeter mercury, and if the pressure is less than 10 millimeter mercury, the LES used to relax and that will let the food pass into the stomach. So further, if there is a decrease in the pressure, that can happen the regurgitation or the flow back of the stomach contents into the esophagus and can cause symptoms. So GERD occurs when the lower esophageal sphincter has a low resting pressure and the stomach contents leak back or a reflux into the esophagus, and therefore the accurate measurement of the LES pressure is of great importance for the diagnosis of GERD. Okay, so this is important. Accurate measurement of the pressure, lower esophageal sphincter pressure, is of the greater importance for the diagnosis of GERD. Okay, so some very important point regarding the GERD. I think you got the point. You are getting many information from that slide. So, and the GAD, other options we can see. So one of the options were Barrett's esophagus. So what is a Barrett's esophagus? Whether Barrett's esophagus causes GERD, or because of GERD Barrett's esophagus is forming, that we can get the information out of this point. So GERD may lead to Barrett's esophagus, which is a type of intestinal metaplasia. Okay, this is another important point. It is an intestinal metaplasia. That means the changes of the epithelial cells from squamous to intestinal columnar epithelium. Okay, so squamous epithelium is getting changed to that intestinal columnar epithelium. That metaplasia is happening in the esophagus. That is known as the Barrett's esophagus. And GERD is because of the GERD we can get Barrett's esophagus. So it is a precursor condition of the esophageal cancer. Okay, so that metaplasia, it is a precursor condition for the esophageal cancer. Okay, so that's a Barrett's esophagus. So moving on to the ninth question in our series: which area of the brain contains the control center for voluntary movements of specific body parts? So this is the key point in this question: voluntary movement of specific body parts. Voluntary movement of specific body parts. So there is a center, and which area of the brain contains that control center? So you should know what is the control center for the voluntary movement of the specific body parts and where it is located. So it is little complicated question. Okay, so two things you should understood about this question: where is the control center for the voluntary movements of specific body parts and in which part of the brain it is located. Okay, so the options are option number A, central sulcus; option number B, Sylvian fissure; option number C, precentral sulcus, it is precentral sulcus; and option number D, premotor cortex. So where is the center, control center for the voluntary movements of specific body parts is located? So that is the question. So the answer is option number C, that is a precentral sulcus, central sulcus. So another slide which I am going to explain is very important. So the frontal lobe, the first thing is so this is located in the frontal lobe. Okay, so that you should understand first, and from where in frontal lobe, that will be explaining now. So the frontal lobe is located at the front of each cerebral hemisphere and positions in front of the parietal lobe and above and in front of the temporal lobe. So this is the position of frontal lobe, and this frontal lobe is separated from the parietal lobe by a space between the tissues called the central sulcus. Okay, so first of all, the first point that you need to remember from the frontal lobe is the central sulcus. That means the frontal lobe and the parietal lobe is separated by a space between the tissues called as the central sulcus, and from the temporal lobe by a deep fold called the lateral sulcus. Okay, so central sulcus is there, and from the temporal lobe there is a deep fold called as the lateral sulcus, which is also known as the Sylvian fissure. Okay, so 3 points: central sulcus, what is central sulcus, what is the lateral sulcus, and the other name for the lateral sulcus, that is a Sylvian fissure. So coming to the question what I have asked, the precentral gyrus. Okay, so the precentral gyrus, which forms the posterior border of the frontal lobe, contains the primary motor cortex. So these are the two other important points. This is a primary motor cortex, that is the area 4 under the Brodmann area architecture, which controls the voluntary movements of specific body parts. So which is that the primary motor cortex controls the voluntary movement of specific body parts, and it is located in the precentral gyrus. Okay, so two things we have to understand: what is the primary motor cortex and where it is located. So the primary motor cortex located on the posterior border of the frontal lobe, that is in the central gyrus. Okay, understood. Then what is a precentral gyrus? So the precentral gyrus also contains the premotor cortex, that is the Brodmann area 6. Okay, so this precentral gyrus contains the primary motor cortex and the premotor cortex, primary and pre. In that, primary is the one which controls the voluntary movements of specific body parts. Okay, so this type of questions we can expect in the ESIC, because the ESIC, I think it may concentrate more on the normal physiology and anatomy and like that questions. Okay, so very informative and important question. Moving on to the 10th question in our series. So white cell cast in urine is suggestive of which disease? White cell cast in urine is suggestive of which disease condition? So the options are option number A, renal calculi; option number B, pyelonephritis; option number C, nephrotic syndrome; and option number D, glomerulonephritis. So in which condition you can see white cell cast in urine? Slightly confusing. Because white cell cast, that WBCs can be seen in any of the infections, but in the urine it is little more specific. So the answer is option number B, pyelonephritis. So why pyelonephritis and what is pyelonephritis? That I will be explaining now. So the first of all, the cast represent different disease states. Example, RBC cast are most associated with glomerular disease, whereas the WBC cast are indicative of tubular disease, especially infection and acute pyelonephritis. Okay, so cast will be maybe RBC cast will be there, WBC cast will be there. So this is the differentiating factor. RBC cast can be seen in the glomerular diseases, whereas the WBC cast can be seen in the tubular diseases, especially the infections of the tubules, that means like acute pyelonephritis. So a specific type of urinary cast has been demonstrated in the urine of patients who have acute pyelonephritis. So this cast is characterized by the presence of bacteria in its matrix and appears to be specific for and diagnosis of pyelonephritis. Okay, so the white cell cast that we can see in the pyelonephritis contains bacteria in the matrix and appears to be specific for the diagnosis of pyelonephritis. It is easily demonstrated by the routine urine analysis. Okay, so that's all regarding pyelonephritis. So pyelonephritis, it is an inflammation of the kidney, typically due to a bacterial infection, and the symptoms most often include the fever and flank tenderness. Okay, and other symptoms include nausea, burning with urination, frequent urination, and the complications include pus around the kidney, sepsis, and kidney failure. Okay, so this is in short about the pyelonephritis. What is pyelonephritis? Okay. So understood now that RBC cast and WBC cast in renal diseases. So moving on to the 11th question in our series. What is the gold standard test for osteoporosis? Okay, so what is the definitive diagnostic measure, gold standard test for the diagnosis of osteoporosis? So first one is MRI, the second one is CT scan, third one is the DEXA scan, and final option, all the above options like MRI, CT scan and DEXA scan. So the question is the gold standard test. So you should be specific with your answer. So the answer is option number C, that is the DEXA scan. Okay, DEXA scan. So what is a DEXA scan? So a common diagnostic test for the osteoporosis is bone densitometry. Okay, so the bone densitometry can be evaluated by a dual energy X-ray absorptiometry, and it is pointed out by the World Health Organization as the gold standard to measure the bone mineral density. Okay, so the bone mineral density measurement is the diagnostic test for the osteoporosis, and that can be achieved through DEXA, that is a dual energy X-ray absorptiometry. Dual energy X-ray absorptiometry. Okay, so dual energy X-ray absorptiometry, it is a means of measuring the bone mineral density using spectral imaging. Okay, so here they are using the spectral imaging, the two X-ray beams with different energy levels. These are aimed at the patient's bone. So when soft tissue absorption is subtracted out, the bone mineral density can be determined from the absorption of each beam by the bone. So this is the mechanism by which the osteoporosis can be diagnosed. Okay, so the mineral density and the soft tissue absorption density are calculated and then getting subtracted and coming to a conclusion of osteoporosis by measuring the bone density by a method called as a dual energy X-ray absorption, otherwise known as the DEXA scan. So that's all regarding the DEXA scan. Moving on to the 12th question in our series. Question is, which among the following organism is the causative organism of farmer's lung? Okay, so first of all you should understand what is farmer's lung and what causes farmer's lung. Okay, occupational hazard. So the options are option number A, Aspergillus, option number B, Actinomycetes, option number C, Penicillium, and option number D, Candida. So which is the causative organism for farmer's lung? Sir, that's a question. So the answer is option number B, that is Actinomycetes. So obviously Aspergillus also can cause, but comparatively the commonest organism is the Actinomycetes. Okay, so first of all we will see what is a farmer's lung. So farmer's lung, it is a type of hypersensitivity pneumonitis. Okay, hypersensitivity pneumonitis, that is a hypersensitivity pneumonitis, also known as the extrinsic allergic alveolitis, is an immunologically mediated inflammatory disease of the lung involving the terminal airways. So where it is getting affected? In the terminal airways. So the condition is associated with intense or repeated exposure to inhaled biological dust. So the classical presentation of the farmer's lung include, which results from the inhalation exposure to thermophilic actinomyces species and occasionally from exposure to various Aspergillus species. Okay, so more commonly it is caused by the inhalation exposure to the thermophilic actinomyces species and occasionally due to Aspergillus species. Okay, so that's all regarding the farmer's lung. Now we will move on to the 13th question in our series. So the question is, which are the most common pathogen causing nosocomial infection in ICU? So the most common pathogen causing nosocomial infection in ICU. Nosocomial infection in ICU. Very important question from infection control. So the options are gram-positive organisms. Option number B, gram-negative organisms. Option number C, viruses. And option number D, mycoplasma. So which is the most common pathogen causing the nosocomial infection in ICU? So the list of organisms I will be explaining. So before that, the answer for this question is option number B, that is a gram-negative organisms. Gram-negative organisms. So the epidemiological evidence indicates that the principal nosocomial pathogens include, the main one is the Staphylococcus aureus, Pseudomonas aeruginosa, E. coli, Acinetobacter baumannii, then coagulase negative Staphylococcus. Okay, so these are the main principal nosocomial pathogens. Okay, so the gram-negative organisms like Staphylococcus aureus, Pseudomonas aeruginosa, E. coli, Acinetobacter baumannii, and coagulase negative Staphylococcus. Okay, so that was another important question. Moving on to the second last important question from the series. So where does the fetal erythropoiesis take place first? So you should read the question very carefully. Erythropoiesis, fetus, and the first site. That's the question. So the options are option number A, bone marrow, option number B, liver and spleen, option number C, kidney, and option number D, from all the above sources. Fetal erythropoiesis. Fetal erythropoiesis. So what is the answer? The answer is option number B, that is a liver and spleen, not the bone marrow initially. Okay. So what is erythropoiesis and how it is happening in the fetus? So fetal erythropoiesis take place first in the mesenchymal tissues and subsequently in the liver and spleen. Okay, mesenchymal tissues and then subsequently in the liver and spleen. The production of RBC in the bone marrow gradually starts during the second trimester. Okay, so the initial areas are the mesenchymal tissues and then the liver and the spleen. Okay, so what is erythropoiesis? So erythropoiesis, it is a process which produces the red blood cells, that is the erythrocytes, which is the development from erythropoietic stem cells to mature red blood cells. Okay, so it's a developmental from the erythropoietic stem cells to the mature RBCs. So it is stimulated by, this is another important question that can be asked in the examinations. So this is stimulated by decreased oxygen in the circulation. Okay, so this is stimulated by decreased oxygen in the circulation, which in turn detected by the kidneys, which then secretes the hormone erythropoietin. Okay, so this is a pattern, this is the way. Okay, then that's all regarding the erythropoiesis. Now we can see the last question in our series, and the question is the Starling's law explains which mechanism. Okay, so you should know what is the Starling law, then only I can answer this question. Anyway, we will see the options for this question. So the options are option number A, vision, option number B, hearing, option number C, cardiac output, and option number D, peristalsis. So which pathophysiology is explained by the Starling law? Starling law. So the answer is option number C, that is a cardiac output. Okay, cardiac output. So we know that the Frank Starling law of the heart, also known as the Starling's law and the Frank Starling mechanism, it represents the relationship between stroke volume and end diastolic volume. Okay, stroke volume and end diastolic volume. So this is an easy law. So this law states that the stroke volume of the heart increases in response to an increase in the volume of blood in the ventricles before contraction. That means the end diastolic volume when all other factors remains constant. So if all other factors are constant or it is normal, the stroke volume of the heart, it depends upon the increase in the volume of the blood that remains in the ventricles before contraction. That is the end diastolic volume. So this is the law known as the Starling law of the heart, and it is related to the cardiac output and not with the other options what I have given in the question. Okay, so with that question we are coming to the end of another series of 15 questions, and these 15 questions will definitely will help you to prepare well for your upcoming examination. So any points in this question or any other point you want further discussion, you are free to ask in our comment section. So thank you for watching the video till the end, and I request everyone to keep in touch with us so that we will be uploading another set of questions very easily, and I'm damn sure that these questions will definitely help you for your better preparation for the upcoming examinations. So once again, thank you. See you soon.